As most of the studies, women compose more than 80% of the population, with a mean age of around 55, 56, and a body mass index which is fairly low for a population in our country. The patient profile, as I was mentioning before also, falls most of the category of the patients in C1, C2, and C3, as most of the studies. The amount of report that the patient reported itself in their symptoms is very high in the hands of general physicians and a little lower in our hands, but is close to 90% in the follow-up, which is something very important. The intensity of symptoms, you can see it in the screen there. You got it very similar results for both groups of general physicians and vascular surgeons. And the frequency of symptoms, we see a tendency to increase in the right hand of your screens in both hands, and the numbers are very much similar to those that we find in both groups, vascular and general surgeons. The reported signs by patients at the first visitation, you can see also a very similar number between them and between us. And the prescription treatment in the first visit, you see the numbers there. Most of the patients follow the whole instruction for a 99% in the hands of vasculars, 97% in the hand of vasculars, and 99% in the hand of general physicians. The efficacy of the use of Daflon and the decrease in symptoms is a mild difference in swelling, the one that we compare, perhaps because vascular surgeons tend to be much more precise into define what swelling is, but basically the tendency is the same and the amount and numbers are fairly much the same. The efficacy of the use of Daflon, advices and symptoms show a very similar pattern as the previous slide. And the patient satisfaction moves towards the right, toward very satisfied during the procedure of 60 days and 90 days and the use of Daflon and advices. With this, I am coming to the end of my presentation, but I would like to make some preliminary conclusions. First, there was a trend of younger patients to be relieved earlier than those old ones. And also there is something that we noticed, which is C1, C3, and C2 coming to the possibility that they use a little bit more compression stockings, but we are still trying to figure out, because some of the patients arrive to the office and says to you that they use them as you prescribe it, but not during the time of the consultation, which you never know if it is truth or not, and you have to take this into account, because that's something that in a warmer weather, which is kind of 90 or 85 or 90% of our territory is warm, the people needs to wear some specific compression stockings with a specific fiber and a specification of how high and how to wear it, because otherwise the patient is not going to complain, is not going to wear them in the prescribed way. Hydraulic treatment needs to be achieved after a time, because the symptoms still continue after the end of the term of the procedure, of the follow-up of the whole process. So the patient, most of them, need to be in an extra stage to analyze if they have a hydraulic problem that needs to be solved somehow, perhaps by an endovascular or endovenous procedure. The efficacy of lifestyle advice sample was too small in our study to make a final and general conclusion. Therefore, we need to continue recruiting patients and get more info and more N in order to get to a final conclusion. I'm going to skip to a clinical case. This is something very schematic about what type of patients we see. This is a 53-year-old female, 15 years of vespral pain in the afternoon that was located below the knee, associated with edema. She complained of nocturnal cramps, and a history of mother and grandmother who suffered also from varicose veins. The physical examination showed a C1 in the right limb and a C2, as you can see, in the left limb. The duplex ultrasound showed left greater saphenous vein with incompetence at the saphenofemoral junction that goes all the way down, and right below the knee, it turns into epiphyseal plexus, a multiple epiphyseal plexus, which is kind of the pattern we see most often in our office in our consultations. Again, this is a product we use as a choice of treatment for our patients, Daflon 1000, a package of 30 sachets, 1 sachet per day, and the use of FFMP 1000 or Daflon 1000 showed an improvement in symptoms, less edema, less visceral pain, the quality of life of this patient improved. Of course, there was no improvement in the ultrasound because that's something hydraulic that stays in there, and the patient needed a solution after 30 days or 90 days of treatment with a venoactive drug. We decreased the edema, we improved the symptoms, and now we have a patient ready to accept the procedure. And I want to call the attention of you guys by showing this important paper by Pascarella and collaborators. In a similar fashion as statins show some regression of the plaque in the arterial territory, this paper, this important paper, shows some mild and very discrete but interesting level of remodeling of the valve in a patient with this particular problem. It's not that I'm saying that the patient under a treatment with pharmacological treatment is going to recover the possibility of doing a complete close-up of the valve in the case that the valve is already being destroyed, but it's improving. So we're moving to the tendency of getting to that point where probably in the near future, we're going to have a solution that comes from the pharmacological or from the genetic engineering point of view. That's one of the options, and that's all I have to share with you guys, and I am more than happy to invite you to visit my country either for leisure or academics. Give us the chance to show you guys our country, and I am opening this session for your questions whenever you want. Thank you. All right. We have the first one. Stoking along with drug treatment for 90 days gives satisfactory results, as you told. What do you do after that for long-term management? Yeah, you're right. This is a cohort. We make an instant picture of the problem with this, but we need to solve the hydraulic at the end. So after the treatment, after 30, 60, or 90 days, the patient during that process goes under the studies of a regular duplex ultrasound to analyze perfectly fine what is happening, and then at the end of the term, we offered a more drastic solution, not only pharmacological, which continue to be under the treatment of that, but also laser, foam, or radio frequency is the option of choice in our environment in Colombia. I have another one. What, according to you, is the main reason explaining that general physicians lost only 8 patients versus much more at a specialist level? That's a very interesting question. And I really think that the time that the general physicians spend with the patient could be a little bit longer, and they can make a report in a much better way than we do. So that's one of the reasons. They do a better click, probably. There is something that we have to learn from them in order to adapt that to our practice and improve it.